The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flight Bridge Ed in their entirety.
In this episode of the Fast Archives, we're releasing a talk from Michael Lauria called Stayin Alive, Impella Device, and Left Ventricular Mechanical Circulatory Support in Critical Care Transport. Michael is a former PJ, a paramedic, and a physician currently serving as an EMS and Critical Care Fellow at the University of New Mexico Health Science Center, and also the Associate Medical Director and an active flight physician for UNMH Lifeguard. He also happens to be the Chief Medical Director for Flight Bridge Ed. In this talk, Michael dives into the Impella device, providing valuable insights into left ventricular assist devices and our interactions with them in critical care transport medicine. This talk offers a solid foundation as your starting point into learning more about LVAD therapy. If you're looking for more talks like this, we've recently released a few other episodes from the Fast Archives that you might enjoy as well. Go back and check them out. Thanks so much for listening.
Today I am going to talk to you about the Impella device, which is a fantastic mechanical circulatory device, and we're going to go through a lot of it here today. What I will point out that I don't quite have enough time to talk about today is things like the decision-making algorithm of how we decide to put an Impella in, which is really cool, but generally by the time they call us to transport these patients, that's already done and taken care of. The technique for placement, really, really cool. If you can get into the cath lab with some of your interventionalists and see how it actually goes in and see how it works, phenomenal educational experience. And finally, the evidence regarding benefit. Definitely not going to wade into the balloon pump versus Impella device debate today. So what I want to kind of go through is just a little bit of understanding about who gets the Impella device, indications and the role of the device, to understand how it works, specifically the physiology, because I think that's germane to a lot of the troubleshooting and how you manage these devices, the transport assessment. I really want to get into the nuts and bolts of at the bedside, exactly what you're going to do and what you should look for and look at to make sure you have a very smooth transport. And finally, we're going to go through some troubleshooting and some examples of how you manage the device when things don't go quite as you plan. So let's start out with understanding the indication for the device. Well, to start out with actually what it is, I know a lot of you are familiar with it, but just to make sure we're all on the same page, the Impella is actually a small impeller that's embedded in a device that goes up through the aorta, across the aortic valve. Part of it sits inside the ventricle. It actually sucks blood from in the ventricle and ejects it into the aorta using this impeller, which is basically like the propeller on a boat. So who gets an Impella? Well, basically, you can think of an Impella as a temporary device that acts like a bridge from instability to something else longitudinally. And when we think about that, it's essentially a bridge through high-risk cath. So patients that are getting reperfusion therapy or they're going to get stented, that they have a large section of the heart, a large chunk of myocardium at risk. What they can do is actually put an Impella in before the procedure, kind of like a safety net for that left ventricle. It's a bridge to recovery. We see this all the time. Patients who come in hemodynamically unstable, they're having a STEMI, they go to the cath lab, they come out with an Impella, and over the course of several days, we're able to wean the power down on this thing and actually take it out, and these patients walk home. A bridge to CABG, or a durable or permanent ventricular assist device. Sometimes we use it in that setting. And also a bridge to a decision. Sometimes we just need to buy ourselves some time and stabilize the patient where we come up with a plan. And finally, we'll use it in some of our ECMO patients to actually vent the left ventricle or take some blood out of that left ventricle. So what's it a bridge over, right? Well, this is somewhat intuitive. Most people understand that it's actually a bridge through cardiogenic shock. But I think it's really, really important as critical care transport providers that we understand what we're talking about and what the actual definition is. Because I think we all understand that it's basically a problem with perfusion, so hypotension secondary to a problem with the heart. But it's important to understand how our cardiology and interventional colleagues actually define it. And the way we define it is essentially sustained hypotension with two features. Number one, they'll have elevated LVEDPs, so elevated left ventricular filling pressures. In other words, a wedge pressure, technically defined being above 18, and then reduced cardiac output. So an index that is less than 1.8 or less than 2.2 with the addition of pressors and inotropes. Now, our friends at the Society for Cardiac Angiography and Intervention, so SCAI, as we like to call it, came up with this fantastic, much better definition and essentially scoring or staging of cardiogenic shock. And what's important to realize is when it comes to mechanical circulatory support, as we work up this pyramid from patients that are fine to the patients at the red at the top that are in extremis and we're crashing onto ECMO, our Impella patients sit essentially here in the C and D categories. And what you can think of as a category C cardiogenic shock patient is basically someone who you're starting on BiPAP, starting to give them some pressor, and D is essentially you are ramping up the pressures, they're on rocket fuel and they're not responding. And that's why they need mechanical circulatory support. It's also important to understand who we won't put Impellas in. As it turns out, if there's essentially any problem with your aortic valve, if it's floppy and open and incompetent, if it's way too small to get a device through, so aortic stenosis, or it's mechanical, we can't really put it in. Likewise, if there's a big thrombus sitting in that LV, it doesn't really work like your pool vacuum very well. So if you kind of stick that thing in the LV and it sucks in a whole bunch of clot, it's not going to do its job the way it's supposed to, and it will probably malfunction. And of course, there's patients with terrible peripheral arterial disease, nasty, tortuous, calcified arteries that you literally cannot snake this thing up to the heart. So sadly, those patients don't get Impellas. Now let's understand how it works. So really what it does physiologically, and we kind of touched on this already, but it goes across the aortic valve. It has an inlet. It's going to suck blood out of the ventricle and shoot it out into the aorta. So physiologically, what does that do? And how does that help in the setting of cardiogenic shock? Well, it really does two things, and these are really important. The first one's pretty intuitive based upon what I explained to you, right? It improves cardiac output. By taking blood out of the ventricle and shoving it into the aorta, it's going to overall improve your cardiac output. But perhaps what's equally important is how it actually helps the heart heal, how it offloads the heart. You can imagine this big, distended, sick ventricle that can't pump blood out. You can kind of think of it like as a wet towel. It's kind of how I think of it. And when you twist that wet towel and increase the tension in that towel, all the water comes out, right? Well, if you have a myocardial wall that's super stretched and the wall tension is really, really high, no blood's going to get into that muscle. So actually, by offloading that ventricle and sucking some of that blood out, you allow the tension in the ventricular wall to go down, for that ventricle to relax, for it to get good perfusion, the perfusion that it needs to do better. From a mechanical standpoint, it also optimizes how that ventricle is going to function, right? Because if we're way over here on the right side of the Frank-Starling curve and that thing is stretched out like an overstretched spring, it can't contract very well. But if you take off some of the volume and let it come back to roughly normal size, we're going to move back here on that Frank-Starling curve and we're going to be doing better. So, by decreasing the wall tension and sucking blood out of the ventricle and pushing it into the aorta and improving your mean arterial pressure, you're essentially improving coronary perfusion. And that is key. And you can see what happens here. Someone's not doing so hot. That gray line on the top, their map's coming down. Their LVEDP is coming up, right? Their wedge pressure is climbing. We put the Impella in and that goes the other way. Their map comes up, their LVEDP comes down, and we're doing way, way better. So let's talk about your transport assessment. This is actually what you're going to do at the bedside when you come up and see a patient with this device. So how you're going to assess them at the bedside? First, keep in mind there is a patient around that Impella. We often, especially in the setting of ECMO and Impellas and all these fancy devices, we tend to get drawn into them and forget that there's a patient attached to it. So look at the patient first. And then what I'll do is I'll go ahead and after I look at the patient, I'm going to go ahead and just scan the monitor. Often because from a cognitive standpoint, that's where my eyes tend to go. Flashy numbers. I am a paramedic at heart. Squirrel. Quarter. Wait, what? Huh? Okay. There we go. So looking at the hemodynamics on the monitor is also really important. It can give you clues to the next steps as you begin to troubleshoot things. Always remember, I think about it as addressing patients with an Impella in cardiogenic shock the same way that I think about patients who do not have an Impella in as cardiogenic shock. In cardiogenic shock. First, starting out and optimizing their oxygenation and ventilation. Optimize the settings on their non-invasive ventilation or vent if they're actually intubated to improve oxygenation. It doesn't matter how much flow of blood is going. If their sats are in the 60s, you're still going to be in trouble. Thinking about stabilizing their hemodynamics, messing around with our pressors, making sure there's adequate afterload, that we're actually putting enough back pressure into those coronaries to perfuse the heart, but not so much that we're giving too much afterload, so we're making it hard for that Impella to inject blood out. A lot of these patients, especially the ones that come in and they're having acute events, they'll come in fluid overloaded. So it's actually really important to think about considering their volume status and then actually looking at the heart and looking at the squeeze and considering, especially if that device is in now, do I need to actually dial back a little bit on my inotropes and perhaps rest the heart, or do I actually need to give them a little bit more and help augment the Impella that's already working for them? Check the device function and positioning. So now we're going to get into the meat and potatoes of things of how you're actually going to look at the device. So this is the automated Impella controller screen. And basically what we're going to do is we're going to look at some of the numbers here. And I'm going to walk you through my scan of this device, how I actually look at the numbers on this device when I walk into a room in the cardiothoracic ICU or an outside hospital to pick up patients. You don't necessarily have to follow this particular scan the way I do it, but come up with a system for yourself that actually makes sense. So when you're walking in and you're overwhelmed, this patient's looking super sick, and you have to translate all this data and come up with a solution and a plan, you can, and you can do it very easily. So this is how I walk through it. I'll go ahead and I'll start out by looking at the aortic sensor pressure and the ventricular sensor pressure, and then scan down and see what's my actual flow through the device. How is this device actually functioning and flowing? I'll scan over here and I'll look at, if it's calibrated appropriately with the appropriate device, what the cardiac output is and what the cardiac output power is, which is a whole cool conversation for another day. And then I'll put that in the context of what it should be doing by looking at the power level on the device. Now, I'll also keep in mind that as I'm going through the numbers, those waveforms are actually important too. Looking at the aortic and the ventricular waveform, pressure waveform, most importantly, their relationship to one another can tell you a lot of information, and we're going to go through that shortly. And then looking down and seeing the motor current. It should always look somewhat sinusoidal. Remember that device is sensing pressure in the ventricle and in the aorta across the aortic valve. So there's always going to be, at least when that valve is closed, a pressure differential, which means that motor has to change its actual current as it's going along. It should be changing if that device is in the right place. And of course, looking at the purge pressures. Now, I cannot emphasize, ultrasound is the way of the future, and when it comes to our cardiac patients, it's super, super important. And in this case, you don't have to be a master echocardiographer to assess this device appropriately. Just getting a peristernal long axis can tell you a lot about how the device is positioned, where it is in place. And it should be from the aortic valve to where we call the teardrop is on the other side of the inlet for blood inside the ventricle. It should be kind of sitting in the middle of the chamber, and it should be about 3 centimeters beyond that aortic valve into the ventricle. I also really like echocardiography because, as it turns out, anytime you put catheters or wires anywhere in or near the heart, you can cause other problems like this. So you should be aware of this in transport, because a giant effusion or a giant hemopericardium could come back to bite you somewhere between point A and point B, and the sending facility should be aware of this. I would really like to know if I put one of these in if I caused the problem. If you don't have access to ultrasound, that's okay. You can still look at it on a good old-fashioned chest x-ray. So you can see here, this patient actually has an ICD in place, but if you look right at that aortic silhouette, you can see where the Impella goes. And our radiology colleagues, knowing that I'm a poor emergency medicine physician, tend to let me know by drawing and pointing arrows that it's actually in the right place. So this is super helpful, and you can see this is what it should look like. It should go around the aorta and sit nicely sort of in the mid-chamber of the ventricle on the x-ray. This is what it shouldn't look like. This was a lovely young lady who had a propranolol overdose, out of hospital cardiac arrest. We put her on ECMO and had to actually put an Impella device in. But because she was so small, we had this big kink in the Impella that was actually able to function just enough to get blood out. But I would describe its function when it's kinked at a 90-degree angle as suboptimal. Next, check the insertion site and the extremity. So the device should sit somewhat like this, right? The first thing you want to do is check that TUI valve or that lock to make sure that the catheter itself is not moving back and forth and changing the position of the Impella. Then I'll take a look at the insertion angle. It should be at like 30 to 45-ish degrees. It should not be flat against the skin because that puts a nice kink in that catheter, and that's not a good thing. The catheter depth, always document it and make sure it hasn't migrated since they put it in the cath lab. And finally, there shouldn't be any evidence of hemorrhage or an expanding hematoma. It's not like an IV where a little bit of blood is dripping out. Remember, this is an arteriotomy going into a relatively high pressure system. So any big or expanding hematoma is a problem, and a problem that probably should be addressed before the patient gets transported. It's made more difficult by the fact that every single platelet in this person's system is not working, and their entire coagulation cascade has been shut down by us, namely, so they can bleed a lot more. So be on the lookout for this stuff. Make sure they have a knee immobilizer on so they can't bend their knee like this. When they actually bend their knee or flex at the knee, what it does is it takes that catheter, that sheath that's in the artery, and bends it up like that. Reefing it up like that can actually tear the artery open, which I don't think I need to tell you is probably a bad thing. Always check for pulses in that extremity. Make sure that they still have really, really good perfusion to that foot. Remember, we put something in an artery, and that can actually block it or decrease blood flow to that extremity, and that's something we need to know about, especially at the receiving facility, so we can actually address it. So it should, all in all, look something like this. You can see the PA catheter there next to the Impella with the knee brace in place. This is more or less how it should look. So let's end off with some of the complications and managing some of these Impella problems and some examples. So just a couple of general notes on important things as we get going here. CPR is absolutely okay. Go ahead and if someone goes into cardiac arrest with one of these devices in, just dial it back to P2 and have at it. Do CPR the regular way you should, including mechanical CPR. Defibrillation, just put the pads on like you normally would and defibrillate them. If they are not in cardiac arrest and they do develop malignant arrhythmias, the nice thing is you can just do your regular ACLS stuff. So treat the rhythms the way you normally would. And an important side note, especially if you have a lot of referring cath labs that will actually, you will go and you'll pick up patients at and bring them to larger centers. The manufacturer actually encourages people initially to put the device on something called autoflow when they put it in. It tends to decrease their cognitive load as they're messing around in the cath lab and doing the other important stuff they need to do. But what it will do is it will automatically adjust the power level to maintain flow. But it sets that at the 3-hour mark, it will immediately go up to P9. Which means that if you're hanging out with this patient or loading them right around the 3-hour mark and everything looks fine, then all of a sudden you have to start to get a whole bunch of alarms, you're gonna need to troubleshoot the device because it just kicked into high gear on you. Alarms, problems, and troubleshooting. So if I could leave you with one important piece of information in terms of troubleshooting these devices, it's this. And the manufacturer, Abiomed, will tell you this. It is preload dependent, afterload sensitive, but I will add that it is positionally somewhat precarious. And here's where I'll thread in some of the human factors stuff, because a lot of the time when you go to these courses or you're trying to troubleshoot these things, people will give you nice acronyms and way to think about stuff. The problem with that is when you're super stressed out and overwhelmed, your brain has a really hard time troubleshooting novel things that you haven't seen before. It takes a lot of mental energy to put all the pieces of the puzzle together and think through things. And actually that strategy, which is called cognitive forcing, doesn't really work very well when we test it. So what I like to do is come up with cognitive behavioral strategies when I see a problem, things I can actually touch, look at, do, and check that will actually bring me naturally to a solution. So if we say something's preload dependent and the device is preload dependent and I'm troubleshooting and working through it, what I'll think about is, okay, check the PA catheter, look at the LV and aortic waveforms, throw a probe on that right heart and IVC to look at what the preload actually is, and then look for bleeding or sources that would cause volume depletion, because that would affect preload. So that's the troubleshooting thing that I work through. And specifically, the numbers that I'll look for are things like the CVP and wedge pressure, making sure those are above 10. And on my POCUS exam, certain parameters of right heart function that could indicate that the problem is not necessarily with preload volume, it's how the right ventricle is sending blood to the left heart. For afterload, if I think about it's an afterload problem, I'll check the A-line, I'll look at my pressors, and if they're on ECMO, and that's part of the math, I will make sure my flows are adjusted correctly to offload that device. And finally, if I'm thinking about positioning, I'll go and look at the motor current, the LV and aortic waveforms, and then check the depth at the catheter site, and finally throw that probe on the heart so I can see where the device actually sits. So remember, regardless of the alarm, always check the patient first and go through all those resuscitative things. But then we're going to work through a couple of problems here to bring it home in terms of looking at how the device is functioning. So this is a very common alarm, a suction alarm. That's going to tell you that it's not getting the blood it needs to through that intake port. And so when I think about these, what I'll do is I'll look at the panel and I'll say, okay, suction alarm. So it's not getting the blood that it needs into the device. So let's go through my little scan here. So I look at the aortic pressure and the ventricular pressure and the aortic and ventricular sensors, and that's kind of weird, right? The diastolic in the ventricle is negative. And if you look at the waveform here, look at how sharp that ventricular waveform, that white wave, comes all the way down like that, specifically in diastole. But in systole, if you look at the top of that white waveform, look how it comes right up into the aortic waveform very nicely. That means in systole, it's actually getting blood flow into the device, but in diastole, it's not. The flow is kind of on the low side. This is actually an Impella 5.5, so I know that a flow of about 4 liters per minute, that's not quite how this device should be performing. The motor current actually looks okay, but kind of like I said, at that power level, I would expect more flow to come out. So low flow. And in diastole, it's getting suction. It's not getting the volume that it needs in there. So what that's telling me is this is a diastolic suction problem that needs volume. It's dependent on the volume coming into the left ventricle, and now I have to figure out why. So I go through my little checklist. Is it a problem with I look at the CVP and the pulmonary pressures on the PA catheter. I'll go ahead. I've already looked at the waveforms. Now I throw a probe on the heart, and I see that IVC collapsed and that right ventricle is clacking away and it's almost empty. I know that this patient preload problem is actually they need some more volume, and I'll give them some volume. Contrast that to this problem, another suction alarm. So you can see the suction alarm up in the upper left-hand corner. You can see the aortic waveform here and the ventricular waveform here are completely separated from one another. That's odd. That means that throughout the entire cardiac cycle, this poor device is trying to suck fluid in, but it can't. It's trying to suck blood in and shoot it out, but it can't, and it's giving you a suction alarm. The flow here is also pretty low. This is an Impella CP, so I know that at max output, it should be at about 3.7, 3.8 liters per minute, but it's not. The motor current looks okay, but the power level is sort of on the high side, and it's still not doing what it should. If it's going through that constantly, I don't necessarily think this is a volume problem. If it's constantly sucking, sometimes it's up against the wall of the ventricle or positioned inappropriately or bent like that picture I showed you. It's constantly giving you a suction alarm. So now I got to think about placement. I have to think about where this thing is or why this thing is misplaced. So I'll go through that same troubleshooting algorithm of taking a look at everything, going ahead and throwing a probe on the heart and seeing where that Impella is sitting inside the ventricle. And as a comparison, the continuous suction is on the top, that second one I showed you, and the diastolic suction is on the bottom. Top one is a positioning problem, bottom is a preload volume problem. So now, as it turns out, going through our last couple of examples, the people at Abiomed are pretty smart. They try to make it Lauria-proof, and so it'll actually tell you sometimes, hey man, this thing's in the ventricle. It ain't supposed to be. And then you can confirm that, and it makes sense looking at this Impella monitor that you can see where the device is. Basically, the ventricular and the aortic waveforms look the same. Both sensors should not look the same. That means they're both in the same place, and in this case, they're both in the ventricle. So you can see here, the flow actually looks okay because it's just flowing really fast all around the left ventricle. The power level and the motor current, however, the motor current is giving you clues. Look at that motor current. There's not a lot of oscillation there, which tells you there's not a lot of change between the inlet and the output, and that is a problem. And finally, at that power level, it looks fine in terms of the output and the flow, but it's always going to look fine if it's in the same place. And finally, the Impella in the aorta, right? This is what it might look like if the whole thing gets pulled out and is sitting in the aorta. As you go through here, you can see, again, the pressures look very similar. The ventricular sensor and the aortic sensor both look like they're an arterial waveform because they're both sitting in the aorta. The flow, again, looks fine because it's just sucking blood out of the aorta and shooting it back into the aorta. The motor current, on the other hand, essentially looks flat. There's no oscillations there as it normally should look. So you know that there's no pressure differential between the input and the outlet. And the power level and the cardiac output look just fine for not so good reasons in this case. So other common problems. Hemolysis, as it turns out, usually not a big problem, but about 50% of patients will experience this. Some of them will need transfusions. Dysrhythmias, we kind of talked about earlier. You can treat them as you normally would treat any dysrhythmia in a person that doesn't have an Impella in. Look for those signs of acute limb ischemia and be on the lookout, especially if a patient is moving around, because they could have pretty substantial and severe bleeding. So going back through things, we talked about understanding why we put the Impella in people. We talked about how it works, how to look at it at the bedside, and finally how to troubleshoot it, or at least some examples when you're having problems. Remember, the device is preload dependent, afterload sensitive, and it's positionally pretty precarious. Come up with your own system of looking through and troubleshooting things so that it can guide you through evaluating preload problems. Look at the PA cath, look at the LV and aortic waveforms, echo that right heart, and look for signs of bleeding or volume loss. Going through, if you're talking about an afterload problem, check the A-line, look at your pressors, or if they're on ECMO, look at your flows. And finally, look at your motor current and the Impella controller, check the depth, look at the echo to see where the Impella is actually positioned. So don't be intimidated by these devices. If you can unlock your understanding of the physiology and come up with a way that you can comfortably work through and troubleshoot these problems, you can really help these patients out. And always feel free to phone a friend. The Impella support team is fantastic anywhere you are. In fact, it's kind of scary. They have an uplink on their phone so the reps can actually see exactly what you're doing. It's kind of funny because I'll call and they'll be like, you pressed this button, didn't you? And I was like, yeah, I kind of did. They're like, this is the problem you're having, right? And I'm like, yeah, that's kind of what I'm seeing. They're like, this is how you got to fix it. I'm like, okay, thanks. And then I tell the sending physician, actually, this is the problem we're having. This is how we need to fix it. If you're interested in more of this stuff, Impella runs a great course. Abiomed, again, no money from them, but I would encourage you guys to check out this course. They run a fantastic in-depth course. And remember, if you understand how to use these devices and you can unlock the physiology in your brain, we can do amazing things for our patients. And we should be doing everything we can as best as we can every single time. Thank you guys so much and enjoy the rest of the conference.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.